From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to our listeners around the world. You're listening to JAMA Surgery Author Interviews. Thank you for joining us. I am your host, Dr. Amalia Cochran. Our topic today is food insecurity in United States surgical patients, and I am speaking with Dr. Annabelle Jones from Harvard Medical School and Brigham and Women's Hospital, and Dr. Seth Berkowitz from the University of North Carolina at Chapel Hill. Welcome to both of you.
Thanks very much.
Yeah, thanks for having us.
I love getting the backstory on projects, and so one of the things that I want to hear about from you all is why you became interested in food insecurity in surgical patients. Was there a specific event or series of them that catalyzed this work?
Yeah, thank you for that question, because I certainly love telling the backstory of the motivation behind this project. Honestly, it goes way back for me. I grew up in a small farming community in upstate New York, very rural, and I myself grew up on a farm. So I was deeply a part of that community. And there were just always stories of a farmer or a farmer help hand who got injured on the farm, ended up having to go to the hospital for trauma or surgical care, and had significant economic impacts of that, including the downstream economic impacts of receiving trauma care, which included things we term now as food insecurity or housing insecurity. I am doing my surgical training in Boston, which, we think of as a very affluent city, not rural upstate New York. And I still, when I meet trauma patients, I so often hear concern in their voice, not so much about what their outcomes are going to look like or what the surgery they're having or had is, but really about how they're going to be able to afford tomorrow and how they're going to be able to continue to put dinner on the table for their families. So that's really the inspiration behind the work that we do.
I also wondered as I was reading through this, because obviously this was some use of quote-unquote big data. What was the biggest challenge that you faced regarding either the data or the specifics of the statistical methods for this work, and how did you navigate those things?
It's definitely difficult. Big data is not one to underestimate. Before this project, I had never had experience with the National Health Interview Survey, which we'll call NHIS. And so the intricacy of the methods within NHIS are complex, and truly it's a great database. So I really was able to navigate that with the help of collaborators, which I really want to thank Seth here because he really was instrumental. He has a lot more experience with this database than I do. And also, I really want to thank the lead author, the senior author on this paper, Dr. Kavitha Ranganathan, my PI, who really had patience, because working with big data, I think it's easy to think, oh, you have a database, you have a question, you'll get an answer immediately. And to really have the patience that working with that project is not necessarily going to be linear and quick.
I was just going to say another thing, too, that I think can make some of this work challenging is that surgeries are very common. And unfortunately, there are lots of traumas in particular, and people may need surgery. But within the space of a given data set that's looking in a given year and is only a sample of the overall population, there may not be all that many people to look at. You may wind up having to combine across different types of surgical cases, or you may not be able to delve as deeply into specific types of patient populations as possible. And so while I think the breadth that a data set like NHIS can offer is really impressive in terms of having national representativeness and things like that, sometimes it can be challenging after you've sort of answered the big picture questions. You always want to take it further and sort of drill down a little bit deeper, and you sometimes run into limitations of the data set when doing that.
Jumping off that point, I think one of the more interesting things that came out of this paper, so one of our major findings was that 11.6% of individuals who reported that they had had surgery in the past year also reported food insecurity. That's compared against 10.5% of individuals who did not have surgery in the past year reporting food insecurity. Where I think that's a really interesting piece of data is the question in NHIS that asks whether you had surgery simply says, did you have surgery in the past year? So that's really up to the individual to answer yes or no. So that could be something as simple as a simple skin excision, an outpatient based procedure, or something as extensive as an oncologic resection or a trauma. So I think there's a lot of breadth within that question. And still, we were seeing that individuals who reported having surgery in the past year reported a higher incidence of food insecurity even after multivariable regression and adjustment for confounders. I think since it includes so many different types of surgeries within that question, we're actually going to be more biased towards the null result of those groups being more similar, right? Individuals who had surgery being more similar to the individuals who did not have surgery. So I think this is really interesting data that we could really dive deeper into in the future.
I thought that was great as well. And I think it gets back to your first question too around what the intersection between food insecurity and surgery or, people who have surgery would be, which, may not be the most intuitive connection in all cases. But what I think Dr. Jones is really great in pointing out is like people are often experiencing the need for surgery, the surgery itself, as a real disruption to their lives, right? I mean, so they may not have been at particularly high risk for food insecurity before or anything, but after a major change in your health condition, after a lot of medical procedures that may have associated costs, after, needing time to recover and being out of work and things like that, someone who may never have thought that they're in those circumstances or would be in those circumstances before may now be experiencing this. And so if that's the mechanism, then, just as Dr. Jones was saying before, then that's probably only going to be most applicable to a subset of all the people who experience surgery. And so the fact that you still find this association, even when knowing that we've got a real mix of different cases in there, suggests that it may just kind of be the tip of the iceberg.
There clearly is a lot of nuance to this. I see a zillion different directions that things could go subsequently. That being said, acknowledging that all of these relationships between food insecurity, SNAP receipt, being a surgical patient are super complex, which of your findings when you did the analysis was the one that you found the most intriguing?
Within the food insecurity space, and when we talk about interventions, there are many options, right? But one that at least is glaring to me is SNAP. The Supplemental Nutrition Assistance Program, or SNAP, is a bipartisan supported program that exists. We have funding for it. And yet there's quite a bit of data out suggesting that there is a what we call SNAP gap. So that is that there is a gap between the number of individuals who are eligible for SNAP benefits and the number of people who are actually enrolled and receiving SNAP benefits. Understanding the SNAP gap is difficult on a federal level because every single state has different regulations as to who can actually be eligible for SNAP. So there's not one set federal, you are eligible and you are not eligible. So in our study, we used household income level of 200% or less of the federal poverty level as an indicator that you might be eligible or most likely eligible for SNAP. And we found within individuals who reported surgery in the past year, only about 40% of those individuals at that income level or less were enrolled in SNAP, which I think is really interesting and something that we could intervene upon.
I want to build out on that a little bit because clearly this gets into the idea of interventions and public health implications for what you have identified with your findings about food insecurity in surgical patients. Are there additional interventions above and beyond, and maybe it's as simple as addressing the SNAP gap that you already alluded to? Are there interventions that we should be looking at the institutional level or at a system level to help address food insecurity in our surgical patients? Because we know that wound healing is a non-starter if you are not well nourished.
Yeah, I think this is a great question, but this is an area where a lot of my work gets into I do think there are a couple important places that we could be getting more involved in. And I say that as a bit of a imposter on a JAMA surgery podcast because I'm a primary care doctor in my own work. I'm not a surgeon. But a thing that I think is a really great analogy is the work that I know the trauma surgery field has done in terms of addressing violence in communities and things like that. And so not only is it providing the appropriate clinical care, but is sort of looking at the social conditions that generate these needs. And I think what we've learned from examples like that is that you probably want to be thinking in two tiers and in parallel, not a one or the other type thing. So one is sort of addressing the social conditions that create these problems in the first place. And then two is any particular clinical modifications or adaptations that need to be done for the specific needs. And so in the case of food insecurity, one level of action that could be taken is in sort of addressing some of the underlying risk factors, right, which have a lot to do with income support, have a lot to do with household structure. And so programs like the expanded child tax credit that provided a lot of support for families, unemployment insurance programs, disability insurance programs, SNAP and WIC as specific food insecurity prevention and addressing programs, I think is really important at a policy level to sort of provide that baseline level of support that anyone might need, whether they had a surgery in the past year or not, whether they had a big trauma or anything like that. These are just sort of general purpose things that put people in the situation of being as healthy as possible and receiving that support. However, as you mentioned, there may be some specific things that go above and beyond that might be useful in the specific surgical case. So the relationship between nutrition and wound healing is extremely well studied. It's very well known that wound healing is not optimal when people are under nutritional stress and those kinds of things. And so you very much could think about developing clinical programs that are meant to provide additional nutritional support in that postoperative period or based on the specifics of patients' type of injury or surgery that they had in order to do that. And so I think you can think of looking at this at two levels where there's, one, a sort of more structural systems-based approach that kind of puts people in the right position, and then a second tier that also incorporates that specific clinical knowledge that only, the surgical care providers will have to know, well, how specifically, given the particulars of this patient's situation, do we need to best support their nutritional status?
Yeah, and I think honestly, one of the best and biggest steps we can start as surgical providers is just in screening. This is such a big problem, and yet when I was reading the literature about there being 10% of individuals that live in Massachusetts are reporting food insecurity, I was shocked by that number. And when I present on that topic and when I talk to other surgeons about that topic, it seems like most people are shocked. And I think as surgical providers, we think so deeply about how do we optimize our patients' nutrition when they're in the hospital, but then they discharge home. And then we see them in clinic 2-4 weeks later, and we aren't thinking about what is their nutritional optimization between those time points. So I think screening is so important. There are multiple validated screens that are quick and simple that we can ask patients either preoperatively or postoperatively, and that's really one of the first steps. And then, as Seth was saying, there are other things that we can really implement depending on the program and the resourcing available, but things as simple as administrative support so that getting enrolled in SNAP is not such a large mental load for patients, because you can only imagine you just underwent a trauma or a large surgery, you are finding out that you are now eligible for SNAP and you are at an income level that you're eligible for SNAP, and yet you are having to deal with medical bills, your own health process. You might not have help at home to be able to fill out the paperwork to sort out actually getting the SNAP benefits. So providing administrative support in that way is one option.
Dr. Jones and Dr. Berkowitz, I really am grateful that I had the opportunity to have this conversation with both of you today. This is a topic that's near and dear to my heart because I practice in an area where the area deprivation index of the surrounding counties is quite high, and food insecurity is obviously highly associated with economic deprivation. And so this is definitely a topic that is pushing me to think about how my group can do these things better.
Yep, really appreciate the opportunity to come on.
Yeah, thank you again for having us.
I am Dr. Amalia Cochran, the web and social media editor for JAMA Surgery, and I've been speaking with Drs. Annabelle Jones and Seth Berkowitz today. This episode was produced by Daniel Morrow and Jessica Watts at the JAMA Network. You can find a link to the manuscript in this episode's show notes, To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.